morning, friends. Good morning, teacher. My name is Roberto Guevara, and I'm going to talk about emphysematous cholecystitis. Definition: emphysematous cholecystitis is a rare, life-threatening, and rapidly progressive complication of the acute cholecystitis. Cystic artery compromise is thought to promote the proliferation of the gas-producing organisms in an anaerobic environment and penetration of gas into the gallbladder wall. The organisms most commonly known isolated are the Clostridium wilki and the Escherichia coli. At pathology, gallbladders with emphysematous cholecystitis have a higher indices of endarteritis, obliterans supporting vascular insufficiency as a causative factor. The complication occurs with higher frequency in patients with diabetes up to 15% and male patients up to 71%. Gallstones may be absent in up to one-third of patients, and there is a high risk of gangrene, and the perforation rate 5 times is higher than in an uncomplicated cholecystitis.
Acute cholecystitis, or this inflammation of the gallbladder, usually comes about because of a gallstone being lodged in the cystic duct. The cystic duct is the one that leaves the gallbladder and connects to the common bile duct. So let's say this person's gallbladder's got a few gallstones in it, and they go to eat a hamburger. The small intestine secretes cholecystokinin, sometimes shortened to CCK, into the blood where it makes its way to the gallbladder, and signals it to squeeze out some bile to give it a hand with digestion of that hamburger. The gallbladder contracts and one of these stones gets lodged right in the cystic duct, which blocks the bile flow. Now what? Well, this person will probably start experiencing some pain, specifically mid-epigastric pain, which happens because the gallbladder is trying to squeeze on a blocked duct. And just like if you squeezed a partly filled balloon with the end blocked off, it physically stretches out and irritates the nerves in the gallbladder and the duct. This can also lead to nausea and vomiting, which can last for long periods of time. And as that gallbladder squeezes more and more, the stone might get even more stuck. And at this point, the bile, being stuck in the same place, or in this state of stasis, becomes a kind of chemical irritant, and causes the mucosa in the walls to start secreting mucus and inflammatory enzymes, which results in some inflammation, distension, and pressure buildup. At this point, there might also start to be some bacterial growth, most commonly E. coli, which is all over the gut, but also Enterococci, Bacteroides fragilis, and Clostridium, which can also be found there. As it sort of starts to balloon up, the pain might start to shift to the right upper quadrant, and it'll be this kind of dull, achy pain that can even radiate up to the right scapula and the shoulders. After a while, bacteria starts invading into the gallbladder wall and eventually through the wall, causing peritonitis, inflammation of the peritoneum, which can cause what's called rebound tenderness, where pain is brought on when pressure is actually taken off the belly rather than when it's applied. Here's another physical exam trick though. We know that while a patient takes in a deep breath, the diaphragm pushes down in the gallbladder. You can apply pressure on the abdomen to keep the abdominal contents from sliding downward. With the abdominal contents roughly pinned in place, you can ask the patient to take a deep breath. And if the diaphragm pushes down on their gallbladder, which remember is pinned in place, this will start to cause pain, forcing the patient to stop breathing in further. And that'd be a positive Murphy's sign, which can help with the diagnosis. Finally, since the bacteria started invading the mucosa and the tissue, the patient's immune system kicks in, ramping up the neutrophils in the blood and leading to neutrophilic leukocytosis, and likely also causing a fever.
Okay, applications in medicine. Clinical findings of the emphysematous cholecystitis may be undistinguishable from those of the AC in some patients. Patients with AC often present with the right upper quadrant pain, fever, and vomiting, a notable tenderness over the gallbladder, and abdominal pain that may increase after a fatty meal. Focal tenderness may be over the gallbladder with the transducer pressure, the sonographic morphic sign, and may also be present in patients with AC. Similar in patients with EC, can present with the right upper quadrant pain, fever, nausea, and vomiting. The literature does not comment on the presence or absence of the Murphy sign for EC. Both diseases can cause an elevation in white blood cell counts and bilirubin, although AC also causes elevated aminotransferase, alkaline phosphate, and amylase. EC also has been noted to be associated with an increase of serum glucose, although EC has been mentioned as a variant of the AC. Some clinical findings and statistics do differ from that later.
At this point, one of two things can happen. First, the stone could fall out of the cystic duct, which is great, and then the symptoms and cholecystitis eventually subside. This actually happens in the majority of cases. The other thing that could happen, though, is that the stone doesn't fall out. And if that's the case, pressure can keep building up, eventually so much so that it starts pushing down on the blood vessels supplying the gallbladder with blood, which means blood can't get to the gallbladder and the tissue starts to get ischemic, leading to gangrenous cell death, which is cell death due to not having enough of a blood supply. As the gallbladder walls weaken, it might eventually perforate or rupture. This causes sharp pain and, if left untreated, could allow the bacteria to get into the blood supply and cause sepsis. If it's allowed to get this far, it's possible the patient needs a cholecystectomy or a removal of the gallbladder. For some patients, though, if the stone gets lodged further down in the common bile duct instead of the cystic ducts, it can start to block the flow of bile from the liver. Because remember that the liver cells help produce bile, right? If those liver cells keep producing bile, but none of it can go anywhere because of this blockage, bile can start to back up into the liver, which increases pressure in the bile ducts and causes the bile to eventually force its way through the tight junctions between the cells lining the bile ducts and make its way into the bloodstream, causing this increase in serum conjugated bilirubin, which is a component of bile, which eventually leads to jaundice or yellowed skin. An important marker that might also be found in someone's blood that has cholecystitis is alkaline phosphatase, or ALP. This is an enzyme found in high amounts in the liver and the bile ducts. So when bile backs up and pressure in the ducts increases, these cells lining the ducts can be damaged and die. And when they die, they can release their ALP, which can then get into the blood. A diagnosis can be confirmed by ultrasound, which can detect stones as well as a sonographic Murphy sign, which is abdominal tenderness from pressure of the ultrasound probe over the gallbladder. Other ultrasound findings include gallbladder wall thickening, buildup of sludge, and distension of the gallbladder or bile duct. A more sensitive study is cholescintigraphy, sometimes referred to as a HIDA scan. In cholescintigraphy, a radio-labeled marker is used to visualize the biliary system. In the case of acute cholecystitis, the ducts are often blocked and the gallbladder can't be seen. A blockage of the biliary system can also be seen with endoscopic retrograde cholangiopancreatography, or ERCP for short. In ERCP, an endoscope with a camera is passed down the mouth in the gastrointestinal tract until it reaches the pancreas. At that point, a contrast dye is injected into the pancreas and the dye is viewed through a fluoroscope. Another approach is magnetic resonance cholangiopancreatography, or MRCP, which visualizes the biliary system with the use of a magnetic resonance machine. Treatment of acute cholecystitis often includes supportive measures, like intravenous fluids, pain management, and antibiotics. Typically, the gallbladder is surgically removed in a procedure called a cholecystectomy. And if it's done laparoscopically, it's often called a lap col for short. Alright, as a quick recap. Acute cholecystitis is inflammation of the gallbladder that's caused by gallstones getting lodged in the cystic duct. Often the disease improves on its own once the stones fall out of the duct. If the stones stay in place, there can be buildup of pressure that can lead to gallbladder ischemia and even rupture. The disease is often diagnosed by ultrasound and treated with a cholecystectomy. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome.
Okay, pros and cons. I just find cons for this matter. Disadvantage of using the ultrasonography in this emphysematous cholecystitis is that extensive gallbladder gas will be interpreted as a non-visualization of the gallbladder, resulting in false negatives results from the scan. And in addition, the characteristic ultrasonography findings of the intraluminal or intramural gas wall may be highly echogenic reflectors on the ultrasonography that may be mistaken with a porcelain gallbladder or else. Okay, it's just applied in Ecuador. In the report I find, it describes the epidemiological characteristics of patients diagnosed with acute cholecystitis who were admitted with a surgical plan in an hospital in Cuenca. When the people in charge were comparing results with previous reports, they mostly observed that these studies have described the higher incidence of female involvement, including a sample of Colombian patients evaluated in a retrospective analysis where it was evidence that the majority of the subjects undergoing emergency choleostoc- cholecystectomies were women, but the higher rate of complications were in older males. Regarding to the age group, the mean age of our population is 43.8 years old, around 44, with under 40 years, the most frequently affected. This agrees with the Paracetamol one proposed in the Ecuadorian population of 164 surgically operated patients. However, these results vary according to the seriousness analyzed. Conclusion: emphysematous cholecystitis is an uncommon variant of the acute cholecystitis, found more often in diabetic patients, that has the potential to be fatal because symptoms of EC are similar to those of AC, but patients are often referred to the sonography department of the initial diagnosis, thus placing the sonographer on the front lines of diagnosis. For this reason, the sonographer must be capable of acquiring through a clinical history of correlating the information with the sonographic findings. An incorrect diagnosis can give way to delayed and or suboptimal treatment with the consequential degradation of the patient's health. The suspicion of emphysematous cholecystitis with sonography will allow the further imaging and testing to take place, thus prospectively and leading to a quicker diagnosis and subsequently immediate life saving intervention. Thank you.